Verapamil caught us attention because it has such a wide range of dosing in primary headache disorders. And from the previous study, we know that it has been demonstrated that the variants of pharmacogenomic phenotypes would affect the therapeutic response of migraine acute treatment medications. And also, we know that they are genetic links actually associated with individualized therapeutic response to verapamil in migraine prevention. And since 2012, we started to have the pharmacogenomic report available in our electronic medical record system. So we're wondering, like, maybe, we could find any association between the pharmacogenomic phenotypes and the responding dose of verapamil. And especially like this pharmacogenomic phenotype, as it indicated, of individualized transporting and metabolic enzyme activity. And in theory, the lower the metabolic enzyme activity, the higher verapamil concentration could be produced by the same dose. So this dose could be more effective, yet at the same time, it could also cause unwanted side effects. So we want to see if we can find any correlations, any associations between the phenotypes and the verapamil doses. So what we did is we used the pharmacogenomic report in the electronic medical system, and as well as baseline demographic data, and to see if we can find any factors associated with verapamil dose. So this is a retrospective study looking into adult patients who had a pharmacogenomic report in the EMR and had used verapamil for migraine prevention. Initially, we found 74 patients, and after excluded for reasons such as there's no documented therapeutic response, we found 33 patients included in the final analysis. And we found a wide range of minimum effective verapamil dose from 20 milligram to 320 milligram. And this is the dose that the smallest total daily dose an individual ever use, subjectively helpful for their migraine prevention. And then we also found a wide range of maximum tolerable verapamil dose from 20 milligram to 480 milligram. And this is the dose, the highest total daily dose individual use without causing any intolerable side effect. And this study was able to look into 6 metabolic enzymes relevant to verapamil in its pharmacogenomic report. And among them, CYP3A4 is actually the most recognizable metabolic enzyme that would affect the verapamil concentration. However, predominantly our cohort is CYP3A4 normal metabolizer, so we were unable to analyze further whether phenotypes of CYP3A4 affect the dose of verapamil. And same goes to CYP1A2, predominantly is 1A2 rapid metabolizer. And then also the same goes to 2B6. It will be the intermediate metabolizer. And then there was a variety of the phenotypes we found for the group of CYP2C9, 2D6, and 3A5. However, after we adjusted for age, sex, smoking status, and body mass index, there was no association between different phenotypes and the verapamil doses. So our pilot study demonstrated that there was a wide range of minimum effective and tolerable verapamil doses in patients with a variety of pharmacogenomic phenotypes in migraine prevention. A small sample size, obviously, is the major limitation of our study, as pharmacogenomic testing is not as common in headache care. And also, like the study, because we used the existed pharmacogenomic report, we were unable to include all relevant metabolic or transporting enzyme for verapamil in the study. So in the future, the larger study or the prospective studies are needed to fully investigate the pharmacogenomic phenotypes and its impact on the migraine preventive medications.